go on to introduce our next speaker, Dr. ANIRUDDHA AGARWAL, who is currently working as a clinical vitreoretinal fellow in the department. Who is working in the Department of Ophthalmology, PGI, and an immensely capable surgeon with an immense set of accolades. And Dr. ANIRUDDHA would be talking to us on recognizing intravitreal neovascularization and give his pearl to us today.
Very good evening. Thank you, ma'am, for this opportunity. Thank you, Dr. Srinivas, for this invitation. I hope I'm audible and the slides are visible.
Yes, yes.
Sure. So for my case, it's a very simple case, and I would like to thank Dr. Apurva Ayachit for sharing this case with us. We discussed this in one of the late-night Retina sessions, and I think it's a very case that gave us a lot of information. Uh, and let's directly jump to the case of this elderly male who's an Asian Indian. And I'd like to focus here on the macular area of the right. Now, as you can see that there is a hemorrhage right in the center, and you have orangish pigmentation in the macular area, and you have presence of fluid. Now, moving on to the fluorescein and indocyanine green angiography, and let's decode here what the diagnosis is. So on the fluorescein angiography on the side, on your left side, you can see in the superior aspect a hyperfluorescence in the macular area and a more hyperfluorescent area inferiorly. Similar appearance is seen on the ICG imaging, and a blown up figure here shows you two vessels which are coming together superiorly in the hyperfluorescent area, and the lesion down below is hyperfluorescent, but it has sort of a heterogeneous nature. It has certain foci which are more hyperfluorescent within the lesion itself. So what are these two? This is how it correlates with the fundus, color fundus photograph. You have the two vessels above, and you have the orange nodule below. Coming to the OCT, now we're studying the lesion number 1, the top lesion here, and you can see that this particular lesion on the OCT shows you the elevation of the RPE and disruption, and you have intraretinal hyperreflectivity along with intraretinal fluid. You also have some hyperreflective foci. A scan just below shows you that beneath the RPE elevation there, you have a hyperreflective area, and you have a rippled sort of an RPE. Now, the diagnosis here is very simple, and what we're dealing with, along with the retinal vascular anastomosis and these features, is a RAP lesion. So this lesion here is a RAP lesion that we need to identify in our patients. Now, what's very interesting is that this patient had another lesion, and let's look at the lesion at the bottom. This particular lesion has on the OCT subretinal fluid with elongated photoreceptors. You have a sort of a humped PED. You also have on the scans below, you have a double layer sign and a tall peak PED. So these are some OCT features which are diagnostic of PCV. So this is a very interesting case where you have one lesion which is representing a retinal angiomatous proliferation and the other one which is a PCV. And I encourage all of you to read this article by Jemmy Chung's group on the consensus nomenclature and non-ICGA features of PCV by their workshop. So they have certain descriptions here of sharp peak PEDs and ring-like PEDs. But what's important is that if you identify these features on the OCT, which I've highlighted, the sharp peak PED, orange nodule, complex PEDs, double layer sign, and fluid compartment, they have a very high area under the curve for diagnosis of PCV. Just the last slide on distinguishing between RAP and PCV, both are hyperfluorescent on fluorescein and ICG. And remember, the ICG again can show hotspots in both. But what's important is that the OCT features are different. You have focal intraretinal hyperreflectivity in a RAP lesion, and you have a PED common, and you may have drusen. And a PCV lesion has the OCT features that I just described. And this is another published case, a similar case to Apurva's case here of a PCV along with a RAP lesion, and this is ophthalmology retina. So I think if you analyze each case, you may have these concomitant lesions. Thank you.
Thank you, Dr. Anirudh. Chitra ma'am, you have anything to say, or you're muted, madam?
It was a great talk, and on to you, Dr. Srinivas.
Thank you, Anirudh. It was an interesting case. I think, Purva, we have seen that case here, the coexisting of RAP and the PCV. So, would you like to say that ICGA is the must in all these cases? Because in some, as we come to the treatment aspect, the RAP, I think it gets treated with any anti-VEGF. But when we look into PCV, definitely like to treat it either with Eylea or the brolucizumab. So, how would you like to go with this, and how many certain cases do we really have the existing find?
Sir, I think that ICG is definitely very important diagnostic, especially when you have a PCV lesion, you want to identify BVMs, you want to identify the polyps. And I think in this particular case, it has helped us pick the additional RAP lesion because anastomosis, I think you can easily pick in ICG. And of course, OCT is mandatory in our cases. And to your second question on the treatment aspect, I think it's important to identify a concomitant RAP lesion because we know it is inherently less responsive to anti-VEGF. And in case you are planning therapy for the polyps separately, like for example, PDT, you already know that which area you need to treat. So in this particular case, if you ask the agent of choice, I think it would be aflibercept monotherapy first for me. But of course, PDT would be a consideration later on. And now with the lack of the dye, I think that's another issue that we are facing.
Purva, can you quickly, do you want to say something on this case?
Yes, thank you so much, Anirudh, for sharing that case. Yes, like Aniruddha said, I think it's important to go into what lesions are there in a particular patient instead of labeling it as one particular entity. I think it's important to identify both entities so that we have that in mind when we are treating and we are looking for lack of response to any one agent.
Yes.
Any choroidal thickness done in this patient?
So, choroidal thickness, we don't routinely do. We just look at the morphology of the choroid. Even to define pachychoroid, we look at the attenuation of the choriocapillaris and enlargement of hallux.
Was it thicker than the?
Yes, sir. It was thicker than usual. It was thicker than
So I
usual.
think one very useful sign, sir, is that you compare it with the retinal thickness. And if the retinal thickness is, so you know that it's about 300 or it's more than 300.
Yeah. So in this case, it was more than that.
Yes, looks like so.
Quick comments from Shobit.
Can I ask Anirudh a question?
Yes.
Anirudh, how often do you see CNVM and PCV patients who are under treatment going ahead and developing RAP lesions later on anti-VEGF?
To be honest, actually, after the ophthalmology retina report, this is the second case from Apurva. I have not seen concomitant PCV and RAP, but we have seen concomitant PCV with chronic CSC sort of spectrum, but RAP lesion I have not seen.
What about CNVMs, which you start treating first with another agent and then you see features developing down the line, you change your therapy?
Yes, we have many eyes with original diagnosis of AMD. We treated them like CNV, and we thought they are type 1 CNV in AMD, but then eventually they evolved into polyps. So that is very common, actually.
That is very common.
Yes, sir.
Anand, sir? Muted, sir. You're muted.
So I agree. I mean, very often nowadays, because of our lowered reliance on angiography, a lot of us, treating patients without doing angiography first step. So very often when we find a side of a kind of a surprise or twist in the tail, then we do an angiography and we sometimes are surprised to find these kind of anastomotic connections. So I think this happens. And this intraretinal neovascularization, as also shown by Anirudh recently, is also, we see this also in post-inflammatory cases also, and secondary CNVMs also. So you need to look out for that in that setting also. So you might be surprised to find it there too.
So one take-home message to all the general ophthalmologists is just reading the OCT might not help. So rather than being labeled as OCT specialist, I think we need to look into the various factors, including the multimodal imaging, which has come up into our recent armamentarium, and then try to diagnose and then try to treat the disease. Thank you, Dr. Anirudh, for sharing this.
Can I ask a question?
Yeah. Yes, Dr. Vinod.
Yeah. Hi, Anirudh. Nice case. So you went on to elaborate the various OCT signs which can indicate that this patient has a polyp. Was ICG not diagnostic of polyp?
No, absolutely, it was. I think this is Apurva's case, and they did diagnose this patient with PCV and RAP very correctly. I just mentioned OCT features because of the publication by Jenny Chang's group, which is highlighting the non-ICG diagnostic features. And I think ICG definitely is important in diagnostic, but I just wanted to highlight the OCT features along with.
Yeah. I think one take-home message should be the OCT characteristics you should accumulate when there is no ICGA. But once you have ICGA, you really don't need to go into the OCT characteristics.
Yes, that was just to elaborate the APOIS criteria, like Apurva just mentioned.
Thank you very much, Dr. Anirudh and Dr. Vinod, for those comments.